Okay, thank you. Well, welcome. So in this brief presentation, I will try to give you an overview of on the impact of climate change on vector-borne diseases, and especially what we are doing at the Institut Pasteur to face them. So a vector-borne disease is considered when the pathogen is transmitted by the bite of a vector, can be a mosquito, a tick, or a fly. This is the case of dengue and malaria, for example, but also of Zika, chikungunya, plague, or Lyme disease. It is estimated that 80% of the world population is exposed to at least one of these diseases, and altogether they are responsible for 1 million deaths every year. Unfortunately, these numbers are likely to increase because of climate change, and all the models agree to say that the impact will be very severe. And there are several reasons for that. The first one is global warming, of course, meaning that vectors can access areas they wouldn't access before, like in Europe, for example. The second thing is the deforestation. Not only it increases the contacts between humans and wildlife, but also if wild animals disappear, the vectors that were used to feed on them will feed on us. The third thing is us. We are always on the move. The airports in London and Paris are hosting more than 100 million passengers a year. This is huge. And that means that if some of these people come from endemic area, they carry pathogens, and if mosquitoes are present around, they can initiate a local cycle of transmission. And that's exactly what we are witnessing now in Europe. And the fourth point is the vectors themselves. They're getting used to us, so their attitude is somehow copying what we are doing. So a typical example of this is the famous, or rather the infamous tiger mosquito, Aedes albopictus. So this one was introduced in Europe in the late 70s, and it is known for transmitting viruses causing Zika, chikungunya, or dengue. For 20 years, it remained confined to Italy, but now the picture is very different. So we see that the vector has colonized all Southern and Central Europe, and getting to unlikely places like Belgium, the Netherlands, Scandinavia, and now the south of the UK, including London. So that means that we need to react, and I'll say a few words about what we are doing here at the Institut Pasteur in Paris and with our partners. So we are a private foundation that is dedicated to biomedical research, and we employ more than 3,000 people coming from all over the world. We have 140 research groups working mostly on infectious diseases, but also on other things like cancer biology, like stem cells, neurogenesis, or cell biology, to cite just a few. We rely on a core of facilities because you need very advanced equipment to deal with genomics, imaging, chemistry, etc. So what you see on that slide, this is too small to be read here, but this is the 25 diseases that WHO has listed as vector-borne. What you see in blue is the number of research groups at Pasteur working on these diseases, and orange are the ones that are planning to work on them. And so you will see that we cover all of them at different levels. So we do experimental work. So we breed, for example, mosquitoes or ticks or flies at the institute, and we monitor how they transmit the pathogens. We also work at the level of epidemiology, so to monitor the evolution of these diseases and to anticipate possible outbreaks. And finally, we have clinical studies where we have different cohorts in different regions. Of course, we are not working alone. We have a network of Institut Pasteur, or Pasteur institutes, that are found on all continents, and this allows us to deal with possible outbreaks everywhere in the world. In addition, we have partners with research institutions, with universities, and actually the UK is our second partner in terms of number. Just to give you a flavor of the things we are currently developing, we are putting a lot of emphasis on vector biology, because the peculiarity of these diseases is the transmission is taking place almost exclusively by the bite of the vector. So if we can control the vector, we can restrict propagation. Another thing that we do, we have a medical center where people, before traveling to endemic area, get vaccinated or get prophylaxis. And thanks to that, we can monitor these people, these travelers, before, during, and after their trip. So this is like a really powerful surveillance network. But this is not enough, so we decided to, a few years ago, to build a new research center on the campus that is fully dedicated to research on vector-borne diseases. And you will quickly understand that working with mosquitoes or ticks is very different compared to working with cells or pathogens in culture. And so the aim is to produce an environment that is fully suitable to monitor the full life cycle of the pathogens, and so to be in the actual, closer to the normal conditions. So this will open in less than 3 years' time now. So the idea is to combine our three main assets. First, our expertise in vector-borne diseases. So the Institut Pasteur worked on these since its creation in the late 19th century, and currently we have more than 40 research groups studying vector-borne diseases. As I mentioned, so we'll have the right infrastructure to work in there. And the third point is to have the appropriate technology. State-of-the-art technology is required to make major discoveries. So from this, you will understand that the center will be interdisciplinary, very integrative, and the aim is to have a holistic view of vector-borne diseases in the current changing climate. This will be open to our partners, national and international partners, and the aim is to make discoveries at every level and to be able to translate these, to anticipate and to react against vector-borne diseases. So I will finish there, and I'll be happy to answer your questions.
All right, thank you very much, Philippe. That was very interesting. I'm going to introduce our other speakers today. So I have Samia Saad, Senior Advisor to the CEO and Strategic Lead for Climate and Health with CEPI. Ellen Tahone, who will be joining us virtually. Hello, Ellen. From the Netherlands, she is a lawyer and public health advocate with Medicines Law and Policy. Then I have Damien An, Executive Director of Next Generation Research at Julius Baer, and Anthony McDonnell, Policy Fellow at the Center for Global Development. So Samia, I'm going to start with you and then go right to Damien. So first question, with the outbreak of COVID now 5 years behind us, what would you say is the biggest threat in infectious diseases, and how are we preparing for it?
The biggest threat is that people have forgotten about the pandemic and think that we've got all the tools that we need. So that from a political will perspective is a challenge. And I think we've had a series in the last 5 years since the COVID-19 outbreak of polycrisis. So we have the cost of living crisis, the energy crisis, wars in the Middle East, in Ukraine, etc. And of course, the climate emergency, which persists, and the nexus of climate change and shifts in precipitation, temperature, and increased outbreaks. So in fact, 60% of pathogens, so with viruses, bacteria, fungi, and parasites, are actually exacerbated by climate change. And as Philippe highlighted, there's shifts in where, especially vector-borne or waterborne diseases are happening, because some places are becoming much hotter. Actually, it's nuanced. So some tropical areas are becoming too hot for mosquitoes. Yet in Paris, what was the Olympic Committee last year most worried about from a health and safety perspective? It was dengue fever outbreaks. So I think the biggest challenge is we need to make sure to policymakers that we make the case that we are trying to make sure we're targeting climate and health resilience at the same time, and that is a cost-effective intervention. And I can give some examples in a minute on what CEPI and who CEPI is to sort of try to tackle some of these issues.
Great, thank you. Damien, I'm going to ask you the same question, and something that Damien said when we had our pre-call to brief for this, is that a Swiss private bank is interested in antimicrobial resistance, and I really want you to go into that.
Okay, first of all, I'm a research analyst at Bank Julius Baer in Switzerland, in Zurich. Well, first of all, compared to my fellow panelists, it's actually kind of odd that I'm sitting here talking about infectious diseases and antimicrobial resistance. But because in the year 2023, towards the end of around in November, I published a research paper on antimicrobial resistance. Okay, and that's scientifically peer-reviewed by a chief scientific officer in Basel, whose company is working on this field. Now, why our bank is involved in working in this field is because, first of all, we are also in charge of a theme which is called future health. Now, future health is very much related to, say, longevity, changing demographics, and also some of the health challenges facing the world. Now, during my research, which I have to really emphasize here, is that because, first of all, as a bank, of course, you talk about the investment opportunities for our investors, for our ecosystem, of entrepreneurs, and so on and so forth. I'm very struck and very surprised that there is so little awareness or so little urgency about the urgency of rising antimicrobial resistance. So for this reason, I published this and would like to use this opportunity to raise greater awareness about this growing challenge. But we can actually talk in greater detail afterwards.
Go into that.
Yeah,
Thank you.
sure.
Which brings us very naturally to Anthony. Hello. Question for the uninitiated. Could you tell us very briefly about antimicrobial resistance and why it is so difficult to get a new antibiotic to the market, and then what excites you most about solutions to get a new one to market?
Great, thank you very much for having me. So antimicrobial resistance is quite simply, we have bacteria, they cause infections. In the 1940s, the first antibiotics came along, through penicillin and a raft thereafter, that could treat bacterial infections. And suddenly, one of the most dangerous illnesses in the world became very treatable. But as most people learn in school, evolution happens and we all learn to adapt to the environments we are in. And unfortunately for us, that includes bacteria, which have adapted to antibiotics. And the stronger ones outlive the antibiotic and then they pass those on to their children. And that leads to antimicrobial resistance. And there's several ways we can stop this. One is we need to reduce the amount of unnecessary use of antibiotics so that bacteria aren't coming into contact with them unless we need them to. And secondly, we need to come up with new antibiotics, as Charlotte mentioned, to replace the ones that are inevitably going to be lost, because we cannot stop resistance if we're using antibiotics. And we want to use antibiotics because they save people's lives. The challenges with new antibiotics are kind of twofold. One, as I mentioned, we want to protect antibiotics from unnecessary use. The ones we want to protect most are the most important antibiotics, and often new antibiotics, because those are ones that are most likely to work in kind of a last phase. If other antibiotics fail, you want to have something that is safe. And so that keeps the volume of drugs very low. And then antibiotics tend to be very cheap. Often we're used to antibiotics being cheap. They've been around for a very long time. Often several antibiotics will work for a patient and it's not clear that they need a newer, more expensive one. And if you have low price and low volume, then you don't need a degree in economics or business to work to recognize that the market isn't going to be very good. There's a few things that excite me a lot at the moment. One of them is diagnostics. At the moment, there's a lot more interest in diagnostics over the last few years. And if we can get investment into exciting diagnostics and use technology and AI to identify whether or not somebody needs an antibiotic and which antibiotic they need that would work best for them, then I think that will allow us to reduce resistance and also to match antibiotics that will work with the patients who need them.
Fantastic. Damien, can I get you to respond to this? The big question is investment, what I understand, of getting new antibiotics to market, and that unlike any other drug, for example, a cancer drug, if I'm a pharmaceutical company, I'm going to push this cancer drug. But if I'm a pharmaceutical company and I've just got a new antimicrobial, the whole thing is you don't want to use it. So pharma companies are more reluctant to invest, and these things can cost billions. And my understanding is the last new class of antibiotics was found in the 1980s, so older than, I guess, most of the people in this room. So can you tell us a bit about the investment? How can we get more investment into finding a new class of antibiotics?
Yeah, I mean, first of all, I think the medical doctors themselves do not want to use, overuse too much or prescribe antibiotics to their to their patients, or antifungals or antivirus, for example, because that could raise or intensify or reinforce this problem, right? I think that's not what we want to achieve. So the stronger doses of antimicrobial resistance will be reserved as a kind of like a backup solution for that. Now, when it comes to investment opportunities, during my research, because I tried to contact or talk to many different farmers, for example, across, even in Switzerland as well, it's quite interesting to see that some large farmers have even exited the space altogether, because under 1% of the total revenues come from antimicrobial resistance. So in other words, all these large farmers are not making enough money. But on the other hand, when it comes to oncology, it is different because it's high margin, it is much more, it's more profitable for the companies. For sure, they will actually put all the focus, dedication to developing oncology drugs. Now, having said that, in order to improve, that's where, I think it's quite special or unique that as someone, a research analyst, for me, working for Bank Julius Baer in Switzerland, they were one of the pioneers when it comes to, say, tackling this topic, because there aren't a lot of, say, investable stocks from that perspective that have large market cap, because most of the companies are very small market caps. You have them based in India, for example, because India actually, or South Asia, has one of the highest burden when it comes to AMR, and then other locations as well. I mean, or in the West, but it's actually very small base companies. But how to increase investment opportunities? That's the reason why I would like to engage with my fellow panelists as to why is it actually that the large farmers are so reluctant. Of course, apart from profitability, maybe from the human perspective, from how we can actually build this ecosystem of different stakeholders, from banks to investors to NGOs to the governments to scientists, or Institut Pasteur, how we can actually come together to build a more resilient ecosystem.
To put the numbers in perspective, I was researching this last week, that it is predicted that by 2050, antimicrobial resistance will kill more people than cardiovascular disease. So it will become, as Anthony, I'm sure you can touch on in a bit, one of the biggest causes of death. And I think there's a Netflix show about a killer fungus out there. I don't know, I don't have Netflix, but it's not, from what I understand, speaking to people, that's not so far out that there is a killer fungus possibly coming for us. So very good we're having this conversation. I want to pivot quickly to Ellen and Samia, and then Philippe, get you to join in. So earlier, was it, Ellen will correct me, last month, the month before? In May, the Pandemic Preparedness Treaty was finally signed after lots of work on your behalf. Ellen, can you please tell us a bit about the treaty, what you like about it, and maybe what you don't like about it and what we can get a bit stronger, and then Sammy, I'll get you to jump in.
Sure. Thank you. And first of all, thank you very much for inviting me. And I regret not being able to be with you, not only because I'm speaking to you from sweltering south of France, where the first heat wave is hitting, and the villages without water. So if my voice goes, you know what's going on. So the pandemic accord there's an agreement amongst the members of the World Health Organization on the pandemic agreement, and what the agreement actually is, it's a response to many of the things that went wrong during COVID-19. In a way, it is a manner of learning from a pandemic, and set out a different international framework, a different set of rules to be better prepared for the next pandemic. The objective of the agreement is to have better frameworks for the prevention, the preparedness, and the response. It touches upon on many different aspects. The agreement is not entirely finalized because an important part that still needs to be negotiated out before the agreement can enter into force, before it can be ratified and enter into force, is an annex that covers pathogen access and benefit sharing. But overall, of course, the importance is a multilateral response to what was also an international failure in many aspects. And the part that we have worked on the most are the sections that deal with access to innovations, access to countermeasures. What we saw during COVID-19 was this phenomenal success of science, public investment in the development of COVID-19 vaccines, and then a colossal failure in the rollout of these vaccines, where low and middle income countries were really at the back of the line, and high income countries were procuring these vaccines multiple times over the needs of their own populations, all while the countries that actually had or would have had the manufacturing capacity and the companies that asked for access to the know-how and access to the technology to be able to help with the scale up and have a more diversified production of these COVID-19 vaccines were told no. The companies that by then had acquired the intellectual property and the know-how to produce these vaccines really established very firm monopolies, perhaps with the exception of AstraZeneca, which was developing and marketing the Oxford University vaccine that had a close collaboration with manufacturers in India. But overall, the issue of sharing of that scientific knowledge, sharing of that manufacturing know-how, was a huge stumbling block during COVID-19. And this is a subject that was it was a difficult subject during the negotiations, and it very quickly showed the fault lines opening up, the sort of traditional fault lines between the countries that were very much sort of running with more pharma-type talking points, and the developing world that said we need firmer commitments. Someone mentioned earlier this morning the role of the private sector in innovation, and that is a very important role. But so is the financing. That is the role of the public sector and public research and the public financing into these to make these kinds of innovations possible. Also very relevant for AMR, by the way. But what did not happen in COVID-19 and doesn't happen in many other cases as well is governments using the leverage of that financing. Billions were spent on the development of the vaccines. That was fantastic. It was great success, in phenomenal scientific success, but a failure in using that leverage, that financing, in saying, here, you come up with the vaccines, but it doesn't mean that you get to say exactly what will happen with them. You will have to share that knowledge with others once it is developed. And that is a subject that has been addressed in the agreement. How that's going to play out in real life remains to be seen. We'll find out when the agreement is being implemented, but it is clearly recognized, and countries have agreed to establishing policies with regard to the public financing and the use of conditions of public financing to have a more equitable distribution of that knowledge.
Yeah. Thank you, Ellen. I think the summary is we get the science right, but we need to get the humanity right behind it. And if the public is financing this, what say does the public get in how a public good is distributed? So, Samia, I've seen you nodding along. Yeah, would you like to jump in on what Ellen said?
So, thank you, Ellen. That really nicely sets the scene as to what some of the political challenges that persist in the pandemic agreement gives us some hope. For those who don't know who CEPI is, it's a bit of a tongue twister, Coalition for Epidemic Preparedness Innovations. CEPI's easier, was set up and launched in 2017 post the West Africa Ebola outbreaks in 2014-15. Why? Precisely because outbreak diseases are unpredictable. So it's very difficult to convince the private sector to invest and take that risk alone. So CEPI was set up as a multilateral partnership funded largely by governments, by the way, not just the G7, but Malaysia, thank you, is the Malaysian government, Singapore, Ethiopia, Senegal, Mexico, all recognizing that there needs to be some funding of vaccines for viral diseases that cause outbreaks, known and unknown. COVID was our unknown within 3 years of our existence, and we rallied. The challenge that Ellen highlighted was CEPI was the only entity during the COVID pandemic that had access terms, and we exist in terms of making sure the tools that we fund the research for actually reach people in need wherever they are, especially in low middle income countries, right? So that equitable access piece is core to our mission. We were the only entity that had access terms at the R&D, the fundamental point, which Ellen highlights, where public sector philanthropic funding was being used to fund the research. And we required that there was technology and knowledge transfer to the vaccines that we were funding. So AstraZeneca, for example, we funded where we supported them in doing tech transfer to different partners so that they could manufacture in different parts of the world. The pandemic, so we didn't have a level playing field because the high-income countries really cornered a lot of the vaccines, and we had to, with Gavi, UNICEF, WHO, set up something called COVAX, which really we funded the R&D pieces, Gavi, UNICEF funded the procurement and then delivery pieces, WHO set out the normative in a very constrained sort of supply, who should get the vaccines first, of course, frontline healthcare workers, etc. So the agreement gives us hope because there's an agreement, a recognition now that you've got to bring the leverage you have with public sector funding is where you take the risk early on, right, in the R&D stages. And so it's no good coming to negotiate with a private sector company in a constrained supply environment when you procure. You have the leverage early on. And that's what the pandemic agreement, we hope, will now sort of facilitate better and have a better playing field. So I've got we talked about some of the challenges. We've got now a policy environment that talks about some of the hope in terms of trying to make sure we have that leverage earlier on. And then maybe Philippe and I can tag team a little bit on some of the technical solutions and the evidence base we're bringing to policymakers, especially this year at COP, where the government of Brazil has 3 health days, which is unheard of. And there's also going to be a big focus on infectious diseases. So it gives us an opportunity to bring the environmental policymakers and the health policymakers better together.
Perfect. Philippe, yes, would you like to take the baton from there?
Sure, yes. So the key feature here is knowledge. Actually, we like to compare with war, you need to know the enemy. And this is true at every level. So that means we need to work on existing pathogens, but also on the ones we don't know yet. And this requires investigation, curiosity, and I can tell you that it is very hard to get these projects funded. I can give the example of my colleague Arnaud Fontanet, where 15 years ago, he decided to work on Zika viruses, and I remember some colleagues said, why do you bother? Because Zika was barely known for a few cases here and there in Africa. 5 years later, Zika went all around the planet. And so it's really critical to be able to invest in the discovery at every level, not just work. Often the research or the funding for research comes as a reaction. COVID crisis was a typical one, but actually what's really critical is anticipation. And this can come from research in research institutions, in universities, in pharmaceutical companies, but also we can associate the public with that. Typically when around Paris, in a Forêt de Sénart, we see quite a lot of ticks in there, and so we encourage the public to send them some find ticks stuck on their trousers, to send them to us, and then we can dissect them and determine the DNA content of the type of tick, the type of pathogen or viruses, microbes they might carry. And that's how we can anticipate and so everybody can contribute to research at every level. And the second thing is the long term. So you don't make discoveries in one day. You know, this takes often a long time, and the difficulty that we have for funding, typically for public with private funding, it comes for 2, 3, sometimes 5 years. So that means that often you are limited in time, and actually you need longer investment to make major discoveries. The RNA vaccines that were used to fight the COVID crisis, actually the RNAs that were discovered in the 60s. People like François Jacob in Institut Pasteur was involved, and that's 50 years later that this transited into a product. So the long-term investment is really critical too.
Wonderful, thank you. We've got 9 minutes and 30 seconds left for questions to our wonderful panelists, and we've got microphones going around. If I see any hands, I see one hand down there. Yes.
Hi, thank you so much for an interesting panel. We touched on it very briefly, but I find myself always surprised that tuberculosis is not more discussed when we talk about infectious disease and climate change, given that it's the leading infectious disease killer in the world. I know we discussed antimicrobial resistance, and I'm sure that's a big component of the discussion for tuberculosis, but I'm just curious if you are aware of any work investigating the impact of climate change on tuberculosis, and should we be more worried?
Yep. Who would like to take that?
I mean,
Yeah.
do you want to take it? Go ahead.
You go ahead if you want. I know there is some work in this. I'm not a TB expert, but it's certainly the case that in higher temperature climates you do get more TB, and we are seeing temperatures starting to rise through climate change, and it's on the long list of things we need to be concerned about. But I agree, it probably is an area that needs more concern.
Maybe I can say a few words too. So TB is often associated to poverty, and of course climate change is going to increase poverty. You know, the conditions in which people are exposed to are often responsible for the lack of treatment or the poor treatment. And of course, if we have storms, if we have drought, this will promote poverty and will contribute, maybe not directly, but indirectly to the cost of TB throughout the world. I don't know if you want to add something?
No, that was precisely right. It's the nexus of, again, the climate crisis and hitting the most vulnerable people again, where the health systems are weaker and sort of people then don't necessarily have access to the tools that they need. But there is some hope, because there is now a very large clinical trial, thanks to our friends at the Gates Foundation and the Wellcome Trust, for a new TB vaccine. Actually, there's another one as well in the pipeline. So, you know, the many of you are too young here. I'm a little bit older. So I had my BCG vaccine when I was very little, not very effective. But that vaccine, you know, and even the drugs that we're currently using are decades old, right? So I think there's new opportunities with some of the new technology platforms that we sort of validated during COVID, the innovations in the system innovations, whether it's manufacturing, how we do clinical trials, AI to look at regulatory data. There's a lot of innovations now, and also including computational, that are going to help us design better vaccines, better therapeutics, etc. So the hope is that some of the technological advancements will help us both in the fight against antimicrobial resistance, TB being the biggest killer, and sort of being able to do these things faster. And one of the things that CEPI has set out a challenge for the world is, can we make a new vaccine against a viral pathogen? TB is bacterial, by the way, but viral pathogen in 100 days from when we know the sequence of this new virus. And the reason we think this is, it seems like a big moonshot, but actually during COVID, Philippe highlighted RNA vaccine, RNA work, coronavirus work was decades in the making. It didn't just happen overnight. But from when we knew the sequence of the virus, the COVID-19 virus, it was 326 days till we got a signal that we had a vaccine that could create an immune response. We think we can do it now in 100 days in the near future because of all these system innovations, AI to design better vaccines. And we know, for example, a lot of the vaccines we have, well, we have 2 vaccines for dengue now, they're old-fashioned technologies. They cause reactivity and severe disease because you get something called antibody enhancement because you've got more than one clade circulating at the same time. Now, with the power of looking at large sets of data, using artificial intelligence and computational biology to design, whether it's a TB vaccine or a vaccine against other antimicrobial and bacteria that are causing resistance, or viruses that could cause outbreaks, the power is that you can design and fail quickly so that you can progress quickly. And I think some of the solutions we're excited about is, wouldn't it be great if we could have a combination vaccine for 4 or 5 diseases that are carried by this nasty Aedes mosquito, right? So you hit, from an efficiency, because our policymakers and our financiers are the ones we've got to convince. We've got to bring more efficiency in our R&D and delivery systems in the healthcare system, and have climate and health resilience sort of more bang for your buck, as it were. So a combination vaccine means in lots of places where there are no adult immunization delivery systems, which we discovered during COVID was really scarce, you could hit, chikungunya, Zika, dengue, or Oropouche, which is a new one, by the way, that's cropped up in Brazil last year. They had 4 outbreaks simultaneously carried by this little Aedes mosquito. Wouldn't it be great if we could design a vaccine that could circumvent some of the current challenges with the existing vaccines that are also old-fashioned? So you can't use them in older people or in very young children who are the most vulnerable to these diseases. And that way you really try to help the health system to be more carbon efficient, more people efficient, etc., right? And you're saving more lives because you don't know which of these outbreaks is going to happen when. And the other innovation I think that is really powerful is bringing mathematical modelers and biological modelers together to predict, as the temperature increases, as mosquito habitats change, etc., or where people are migrating to because people are using farming in different ways, you've got refugees, movements, etc. Modeling all those population societal pieces, mapping them over with sort of where mosquitoes are moving to. You can hopefully predict better using sort of historical evidence, but extrapolate to where these outbreaks might happen in the future, and then be able to inform the government of Malaysia or the government of the UK or the government of France or the government of Indonesia, where is the next dengue or Zika or West Nile fever virus going to appear, and what kind of size of a stockpile of vaccines or antimicrobials do we need that is efficient, right? So again, it's bringing the terms of, can we be more efficient in the tools and use the innovations that to sort of bring more efficiency in the system? By that way, we're preventing people going into hospital and reducing our carbon footprint. So it's both health adaptation and mitigation to climate change.
That's incredible. Thank you. I've got 1 minute and 30 seconds left. Do we have another question? Yes, we've got microphones coming around over here. I saw a hand up back there. Yes. Here we go. 1 minute and 22 seconds.
Hi. Just a quick question. The previous panel and this panel have been discussing the sort of problems we're having under the assumption that the international rules-based order that we've all been under, the multilateral system, philanthropy, as well as ODA, which has essentially been running it for the last 50 years, is going to continue in the ways that we've known it, which I think all indication is that it's not. So how do we respond to that when a whole new order has to be put into place to make whatever we're discussing happen? And by the way, I'm Maliha Khan from Women Deliver.
Great. Thank you. Great question. Ellen, can I get you, you've been working with all these organizations, can I get you to chirp in?
I get the easy one, right?
Yes.
No, but that is of course the dark cloud hanging over a lot of the progress that we've been discussing. But I just wanted to make a couple of comments before I say some more about that. I think a recognition and a revaluing somehow of the role of the public sector is really key. If you look at where the successes in disease outbreak and responses to diseases come from, that it depends hugely on public sector investment. And I think it's also fine to say there are certain areas of innovation where we should not be counting on pharmaceutical companies. They have a certain roles to play, but if it isn't driven by the public sector, it will not happen. Further, in order to have uptake of the products, we can develop the most wonderful vaccines, but if there is no uptake, we've got continue to have the problems. That requires equity, but also solidarity in the system, because in fact, if people don't feel they're part of a larger community and of a community in which solidarity is key, it will continue to be a challenge to persuade people to participate in, because in fact it's an act of public health, taking vaccines. You protect yourself, but you also protect the greater good, but the greater good needs to be there. In how's all of this playing out in the changing multilateral environment, the changing global health financing environment? I think we're going to see much more activity at regional level. Countries at the regional level coming together and also filling gaps that are being created by the current political situation and the challenges to the multilateral system. But I do take some hope and optimism from the pandemic agreement. There was a spirit in Geneva of we need to come together on this, and we need to make this happen. So I'm not ready to declare the multilateral system dead as yet. But I do think we're going to see a lot more activity and developments at the regional level, and that can also have a lot of positive further developments, of course, including for science and innovation.
Wonderful. Thank you so much. I like that we can end on a somewhat hopeful, positive note. Thank you all for the questions, and thank my panelists. That was a really interesting discussion, and I learned a lot. Thank you.